Hello, my name is Tasha Wade, and I am an assistant professor at UC San Diego. I've had the privilege of being part of ABCD basically since its start and launch, at actually multiple sites in multiple roles, first as a graduate student, then a postdoc, and now as a co-I at our UCSD data collection site. I've also been a member of the substance use work group for quite a few years now, since 2018, and I'm on a number of other different work groups, including the professional development work group, novel technologies, and others. Though substance use really does have my heart in many, many ways. And so I'm excited to share with you some information about our substance use protocol in ABCD. And I want to first make sure to give credit where credit is due, and that is to say that a lot of the information here in slides specifically are taken from Dr. Krista Lisdahl and Dr. Alex Wallace, who have provided slides, information, answered my questions, and also helped lead our substance use work group. So with that, let's get started. So the goal of today really is to summarize our substance use module for ABCD and all the different measures we use, how things have changed over time. And I'm actually going to spend a lot more time than in a prior ReproNim substance use protocol video talking about how you can use this data, because we are getting to the point where we can do some really exciting analyses in ABCD, and I want to make sure you know how to ask your research questions and answer your research questions most effectively and without least frustration. Because I know a big part of the ABCD challenge of working with ABCD data is the fact that it's confusing at times, and there's a lot of it, and we ask things in different ways. So I hopefully will help make that a little bit more clear, at least in regards to the substance use protocol. ABCD, as you are likely already aware as you're going through this course and watching this specific video, really aims to look at the relationship between adolescent substance use and various factors of health and well-being, including specifically one of our aims in the latest funding grant was to look at and characterize the relationship between mental health and substance use, as well as to specify how use of different substances, including cannabis, alcohol, tobacco, with this focus, especially these days, on vaping, and caffeine affect developmental outcomes and how neural, cognitive, emotional, and environmental factors influence substance use risk, involvement, and progression. Especially that objective 7 is a lot. There's so many different ways you can approach this, and there's so many different types of questions you need to ask to be able to understand how each individual substance on its own versus co-use of substances versus age of onset versus expectations, how all of these different things work together to really impact youth as they age and develop. And so that's one reason the substance use protocol really gets quite complicated in ABCD. But again, hopefully we're going to clarify some of the mysteries of it today. But first, I want to just take a step back and remind us all of why is it that ABCD is so focused on substance use. Of course, NIDA is our primary funder. That's one major reason why we should all have substance use at least in mind. The other is that substance use is incredibly, incredibly prevalent even at young ages. Initiation and escalation of substance use really occurs during adolescence. And in some cases, it might even appear to be developmentally normative to have adolescent substance use going on. Substance use tends to peak in young adulthood. So when somebody is college age or kind of starting out on their own for the first time, we see higher levels of substance use. And yet we know very little about those first few years that kids tend to start experimenting with and initiating substance use. We know very little about anything before the age of 12. And it's hard when we don't have data before somebody starts using to then try to identify the etiology and consequences of substance use, which is all why ABCD started at ages 9 and 10 when our participants were mostly substance naive. And we expect, and I'll show you at the very end a tiny bit of data, that we are going to see our participants use more substances over time. And this is because of other studies such as Monitoring the Future, or here I have some SAMHSA data showing the amount of past month alcohol use by age, so that the darkest group here, this dark blue, that's overall prevalence, but then if you look just to the right, this teal group here are 12 to 17-year-olds, which would encompass all of ABCD up to this point. And between 12 and 17, we see that almost 7% have engaged in past month alcohol use. And that's not no one. That's, especially if you're including 12, 13, 14, 15-year-olds, that's quite a large percentage of the population. Almost 4% have then engaged in past month binge drinking use. And if we jump over to the substance use disorder side, we see that prevalence of substance use disorder, even in teens, is fairly high, in that 8.5% of teens can meet criteria for a substance use disorder within the past year, in those kids who are between the ages of 12 to 17. And of course, this jumps up much higher as soon as we hit the 18 to 25 range. And that's our highest prevalence of substance use disorder in the population. So it's concerning. We know that the brain is developing. We need to know more about this. And that's why ABCD exists. And that's why there's so much substance use data and so many ways to look at it, that we hope all of you will help us figure out some of these questions and really address ABCD's objectives through this data set. So what are some of the types of questions we are hoping to address in ABCD, and again, that you can contribute to? Well, we want to know, what are the risk and resilience factors leading to differential substance use trajectories? So who is it that's going to start and use maybe just because they're at a party, but never actually use outside of that? So we don't need to potentially worry about them as much as the kids who are going to use one time on their own and then keep using on their own and develop dependence very early on, or any other such trajectories. What's going to help kids stop altogether, even if they have been using in their teens and young adulthood? We want to know, are there gateway interactions between uses of different substances? If you vape first, does that make you more likely to use cigarettes down the line and other combustible products? Is cannabis a gateway drug? What about alcohol? Are kids using less alcohol because they're using other things now that there's so many other highly popular substances out there too? What are the effects of repeated substance use, including polysubstance use, on neurocognitive, emotional, and physical development? We know that there's lots of concerns about heart health and lung health with different substances in later middle adulthood and older adulthood. But what about in adolescence? Does this impact their abilities to breathe well and just generally be healthy? How does it affect their cognitive skills and performance, which is especially key when they're still in school and actively needing to remember things and learn things and be engaged in a much more demanding fashion than sometimes we experience out in the real world? How does psychopathology alter, and how is it modified by substance use patterns? Does it change dramatically? What are the effects of individual genetic, behavioral, neurobiological, and environmental differences on risk profiles and substance use outcomes? For these questions, we're hoping to use basically everything else you're learning about in ReproNim to answer that one, right? We've got the genetics, we've got all sorts of family history, hereditary information, we've got behavioral information, we've got neurobiological through neuroimaging, as well as all of our neurocognitive tests. We get all sorts of environmental information based on self-report and linked external data. So there's a lot to work with, a lot of really great information we're hoping to derive from this study. And so as I get into the protocol, I think, again, credit needs to be given where it is due. And that's that we have this large work group that has changed slightly over time, but this is our current, as of 2025, work group status. We've had the same fearless leaders all the way through ABCD so far, with Mary Heitzig at University of Michigan and Dr. Krista Lisdahl at University of Wisconsin-Milwaukee co-chairing the work group. Within the past couple of years, we also have a vice chair, Dr. Alex Wallace, who's really helped especially streamline and improve the timeline fallback. And then we have, as listed here, all these wonderful different work group members who all contribute their knowledge or expertise in different substance use domains, in their work in different populations and across the country, to really help us understand. And I'll especially say that some of our trainees are some of the most helpful, because they tell us what is the protocol actually like when we run it with our participants, and have been just an invaluable resource in helping us shape the study to do the best data collection and acquire the best data we can. So this is our substance use protocol. I'm going to go through each line by line. This is going to be a lot. There's PDFs of this, or there's a PDF of these slides that should be available to you, so that you can have this as a resource in the future if you're trying to figure out which one is, like, where am I going to find that survey? What does it look like? What kind of questions, and when does it appear? So the first thing that you want to be aware of that we ask about is the participant's last use survey. So if you want to look at anything with things like acute substance use, have they used within the last 24 hours? Or if you want to control for and make sure that they have not used within the last 24 hours of whatever measures you're looking at, you're going to want to use the plus form. Now, some of our participants come in over multiple days to complete their study sessions. Some of them might even come in for several days in a row, 3 or 4 days, or a couple weeks apart. Because of that, every time they come in, they complete a plus form. So there's going to be multiple plus forms for each visit. So if you were really interested in cognition or neuroimaging and you're concerned about what they have used in the past 24 hours, you need to make sure that you are matching up the date for the plus form of the visit that they completed, that protocol element, such as neuroimaging, with the day that you're grabbing the plus form from, so that you can make sure you're controlling for what you want. So again, this measure is looking at and asking them about how recently they've used each medicine, including CBD for medicinal reasons, as well as tobacco and caffeine products. All the other medication use is prescription medication. We also have other medical history that is probably likely going to be covered by the physical health work group. All their other prescription medications are logged on a medication survey and medical health survey. But for this one, this is just last 24 hours. And again, that's the plus form. Now, because ABCD started, again, when our participants were largely substance naive at ages 9 and 10, we start with very, very low substance use information, including asking about low-level exposure, such as sipping, single puffs of different substances. And so every single participant is, when they go through their substance use protocol, first from baseline through year 2, we're asked have they heard of a substance, because if they hadn't heard of a substance, we didn't want to teach them about it. We didn't want to ask them about things that they wouldn't be knowledgeable about. So if they'd heard of a substance, which the vast majority had heard of things like alcohol and even marijuana and tobacco, we then ask them, have you had any exposure? Have you had any sips? Have you ever puffed a tobacco cigarette or other nicotine product? And so this is to capture those very first experiences with use. And these were all given from baseline through year 7. We don't give it anymore as our youth are so much older now. And there are follow-up questions to each of these, but they only occur during the first year of endorsement. So if a participant at year 2, when they're 11 or 12 years old, first told us that they'd sipped alcohol, they'd have a lot more follow-up questions than in the subsequent years if all they were reporting is alcohol sipping. Now, for those participants who said that they used more than a sip or puff, we give them some questionnaires regarding their subjective response to alcohol or tobacco or marijuana products. I will note that there was an issue that for a couple of years, I believe it was years 2 and 3, and maybe part of year 4, where not all participants were given the subjective response to tobacco questionnaire, but we then backfilled, and even those who reported on a prior year, we went back and said, hey, tell us about those first responses to tobacco. So again, this is about sensitivity to their initial responses to alcohol or tobacco or marijuana. Alcohol was given at all years, whereas tobacco and marijuana really focused on the first time they reported it. We also want to look at problematic use, of course, in ABCD. So if they endorsed more than 2 episodes or days of use in the past year, our participants were gated into answering questions on things like the hangover symptom scale, the Rutgers alcohol problem index, the nicotine dependence scale from the PATH study, as well as the marijuana problem index and the drug problem index. Parents also fill out questionnaires answering about their youth substance use habits, as well as their access to substances and rules around substances. So the community risk and protective factors talks about the availability of substances in the youth environment. There's also the household rules, where parents will say how much they approve of or discipline for substance use. And then there's the substance use household density measure, which talks about how many people in the household are using substances. It talks about secondhand exposure, and it talks about how much, what kind of storage each type of drug receives. So is there a liquor cabinet? Is it locked? Can the teen or teenager access it on their own? Those types of things. We're also very curious about drinking motives and why youth may be using any substances. And so we have the drinking motives questionnaire, we have a marijuana motives questionnaire, we have a tobacco motives questionnaire, we even have things like INS or electronic nicotine delivery systems, and vaping, so basically vaping any substance, or even if it's not necessarily containing a nicotine or cannabis products. We also have a cannabis withdrawal scale to test for those who might be experiencing some cannabis withdrawal symptoms. Again, you can pair that up with things like the plus form to talk about recency of use and what a teen might be experiencing and how does that impact their cognition or mental health or other aspects of functioning. These are each given on the even years for the most part, years 4, 6, and 8. An individual does need to endorse using this substance to actually be gated into answering these questions. And we give them only sporadically every other year because of the fact that we don't want our surveys and our study participants to have to do, 15 or 20 hours of surveys. So we are trying to reduce participant burden where we can. We also are interested in expectancies and how that might shape substance use early on, as well as their trajectories into later substance use and potentially problematic substance use. So we asked about their perceived harm of substances. How much do they think each one will harm them, and at what level? So if they're drinking daily versus just having one drink. They are asked specifically about their alcohol, nicotine, vaping, and then specifically e-cigarette or INS product vaping and marijuana expectancies. These again are given on different years, so year 3, 5, 7, and 9. We did, for a period of time, also ask about sibling use. We've asked about youth's intention to use. So if they have not used a substance yet, we say, do you think that you will soon try alcohol? Do you think you will soon try cannabis or marijuana products? Do you think you'll soon try nicotine or tobacco products? From years 5 through 7, we ask, did the youth have an opportunity to use? So even if they haven't used substances, was there a time where they might have been offered marijuana or some other product and they declined to use it? To see, again, looking at things like resiliency factors. We also ask our youth to report on their peer use, as well as their peers' views on use, because we know that relationally it really matters what your peers are doing and what your peers think, and that shapes a lot of behavior in adolescence. Beyond all of those self-report measures, we also get some toxicology measures to both confirm and inform further what kinds of substances our youth are using. So we do this in a variety of different ways, and it has changed over time. Early on, we do a lot less testing of toxicology for a couple of reasons. The first is substance use is very minimal in these kids, and so we don't, to save money and to save time and burden on our participants, we only test a subset randomly selected of participants unless they endorse and self-report their own use. But we only test a select few because it saves time and money. And so there's also different things that we collect from everybody, such as hair samples, that again, funding limits how much we can actually test that hair. And so we test as many samples as we can. It really varies year by year, and I'll talk more about that in a second. But going in order from this table, so the first thing that we test is the most acute substance exposure is tested through oral fluid. This was given either on earlier ABCD years on a Draeger device, a Draeger 5000, or in the later ABCD years we used Sotoxa. And this gives us roughly 12 to 48 hours of exposure to a full panel of different drugs, including amphetamines, benzodiazepines, cannabis, and primarily and specifically THC, not carboxy-THC, the primary metabolite of THC. We test for cocaine, MDMA, methadone, and methamphetamine. And you can see in the far right column how many are tested each year. Starting in year 4, we started to do urine tests or urine drug screens. This was, again, trying to figure out burden and also expense to maximally test everyone we possibly can. In years 4 through 7, we did test all participants using urine. In year 8, we changed it, so we only test those who did not provide hair or oral fluid. And that's because of the fact that oral fluid gives us a very short window of detection, that 12 to 48 hours, whereas hair gives us a 3-month window of detection. And so urine somewhere in between there, depending on the drug. For cannabis, regular and heavy cannabis users, we can get even up to a month of cannabis detection in urine. And so if we don't have hair samples on the participant to know a wider range of whether or not they might have used substances, it can be nice to get the urine measured too. We do the breathalyzer test. This is, of course, going to be for alcohol, and again, be a very short window of detection. And like I said, we also collect hair from all of our participants. We have great participation in this and individuals who contribute hair samples. And hair is incredibly shelf stable. So there are cabinets at 21 sites across the country full of different human hair samples that are waiting for funding to test. But we have actually tested quite a few of our samples overall at this point. And so at baseline, while we only tested about 5% of our participants' hair samples, by years 2, 4, and 6, we are getting about 50% tested. And we are still hoping to find more money to test even more hair samples. But that is nice to have as many hair samples tested from as many participants as possible on those neuroimaging and full neurocognitive battery years. We also do have a module in the KSADS to test for alcohol use disorder and any other substance use disorder. This is not actually overseen directly by the substance use work group, but our RAs are trained, and our gating in REDCap highlights for RAs to be prompted to administer the alcohol use disorder or any other substance use or drug use disorder KSAD module based on whether the youth reported 2 or more alcohol, cannabis, nicotine, or other drug use episodes. So if somebody says that they've used stimulants multiple times for recreational purposes, they will be gated into a stimulant use disorder module of KSADS. Just because of the fact that we have more substance use being reported and our youth are aging, starting at year 8, we did change the threshold to have 5 or more use episodes before they're given the KSADS module. But this gives us an actual clinical diagnosis, potentially, of a substance use disorder, more than what we get from things like the Rappy Mappy Dappy that I showed you on a couple of tables ago when it just talks about any problematic use. This is an overall diagram of what the substance use protocol looks like. And so it's a lot. Again, hopefully you have PDF slides so you can follow along when you need to and you're doing your data analysis. But starting in the top left, as I mentioned, every single participant, every single time they come in, completes the plus form. In years baseline through year 3, we did ask or year 2, I apologize. Baseline through year 2, we first ask about heard of. Did our participants, have they heard of each drug? If they've heard of a drug, they then go into the follow-up questions. Starting at year 3, we ask every single participant, in the past year or since we last saw you, have you tried blank? Or have you used blank? If they have endorsed that, we ask, was this the first time you used? And we get some more information on their first use and experiences. If they endorse low-level use during this part of the interview, then we get information on that, whether it's sipping or puffing or tasting nicotine or cannabis products. And then if they've endorsed a full unit of use, so more than a sip or more than just trying any other substance, we do complete a timeline follow-back. At baseline, the timeline follow-back was 6 months, and then we get an estimated lifetime from them as well. Whereas starting at year 1, every single time they come in, we give them, in the past year since we last saw you, or if they missed a year, if it had been 14 months instead of 12 months, we do cover that entire period. The first 12 months are in a very detailed fashion. The second couple of months are in an estimated fashion, which I'll talk more about in a second. So we go through, we get logged information, and this really helps us look at patterns of substance use. Are they binging every weekend? Are they co-using substances, or are they using alcohol some days, cannabis some days, nicotine others, and then sprinkling in some Molly on other occasions? After we get through that full timeline follow-back, we do follow-up questions. What types of cannabis are they using? Right? So even though we have some of that logged in the timeline follow-back, Do they think it's a high potency THC product? Are they looking for mostly CBD? How about Delta 8? What kind of flavoring do they like in their e-cig? Anything like that. We ask them lots and lots of follow-up questions. Some of which in the later years, because the timeline fallback is taking so much time, are going to be cut back on just for participant burden. We also ask them at the end of the substance use interview about caffeine intake and how much caffeine they've been been using. And we do this guiding them through the different types of caffeine, because it can get confusing to talk about caffeine when they're not sure how much is in this Starbucks drink. So does this drink even have any? What about this protein shake, etc. All participants then are given the substance use attitudes and asked about peer use and sibling use. All participants are asked about substance use expectancies. And then for those who'd reported substance use, they're given all sorts of different alcohol or other substance use measures to look again at problematic use or withdrawal symptoms, motivations, and those types of things. Then for those participants who have endorsed enough use, like we just talked about, they get gated into the KSADS module. So there's a couple things I want to just highlight again. I somewhat mentioned there, but want to make sure you're aware of that become really important as you're trying to code some of this out and run analyses. From baseline to year 2, there is gating for all substances to make sure that the participants have heard of the substance. If a participant has not heard of alcohol at baseline through year 2, they will not be asked any questions about alcohol. Because of this and because of some other measures, you might need to input zeros for some measures if you want to include all participants, if you want to infer that having never heard of alcohol means they have never used alcohol. So this is also relevant when it comes to things like the hangover symptom scale or the Rutgers Alcohol Problem Index. If they have never reported alcohol use, they weren't given that measure. So if you want to say those who have zero alcohol problems compared to those who do have alcohol problems, and you want to include those participants who've never used alcohol, you'll need to infer those zeros and input those zeros. If they used a substance, we may ask about whether their first use or low-level use and subjective effects and have consequences of use. Though again, that does change slightly over time, and I would again recommend you look at those sheets a couple of pages back to go into detail on that. I want to walk you through a couple of more gating examples. And so this is from the substance use interview or substance use patterns interview. So we start by saying, I want to start by asking if you have used any of the following drugs since we last saw you on April 29th, 2018. Have you had a sip of alcohol such as beer, wine, or liquor, such as rum, vodka, gin, or whiskey? If they've endorsed this, then we say, how about a full drink of beer, wine, or liquor, rum, vodka, or whiskey? And then once they get through all of those yes-no questions for each substance, we say, you mentioned earlier that you had a sip of alcohol in the past. I want to ask some more questions about that. Remember, your responses are confidential. We will not share your answers with anyone. How many times have you had a sip of alcohol since the last time we saw you? They give us an estimate of how many times since we last saw them. So they might say, oh, it was just one time. It was at Christmas dinner. Or they might say, I sneak into my dad's garage as much as possible and grab beers whenever I can and just like find the dregs of his empty bottles, right? Like either of those, they give us how many sips. And then we ask them, some people have alcohol as part of religious ceremony, such as in church or at a Seder dinner. Since the last time we saw you, have you had a sip of alcohol that was not part of a religious ceremony? And we get more information on that. So then we say, now I'm going to ask you if you tried these drugs for the first time since the period we last saw you. Was this the first time you tried alcohol, cannabis, cocaine? And we get, what's the first time you tried it and get the date? And then we look at trying to calculate an age of first use onset. And then, again, talking about sipping, I mentioned that if they gate into religious sipping, we will get more information about that. If it's not part of the religious service, we still will ask some other follow-up questions. And then if they've already filled this out at a previous session, they will only answer the number of sips, but not all of these follow-up questions. So how many were part of a religious ceremony will still be asked, but not how old was the first time you had a sip of alcohol. Did you continue to drink alcohol or the drink afterwards? And what type of drink was it? Or was it given to you, or did you sneak it? Those types of questions that follow up. So now I want to spend a decent amount of time talking about the timeline follow back. And this is, again, because of the fact that this is a really key measure in ABCD and one of the things that I think makes our data set so unique. We are getting very clear, detailed patterns of information on how our participants are using substances. And so we're not just able to say, what have you used this, yes, no, in the past month, but how much have you used in the past month? And also look at their other patterns of use, weekdays versus weekends, as well as how much their average use is versus max use, co-use, total days, all sorts of things. So RAs are highly trained in this. We spend a lot of time training our staff on how to give the timeline follow back, including doing things like regular training on different types of drugs. It is interesting to be on RA calls and hear, what are the slang terms in Baltimore versus in San Diego versus in Oregon for different drugs. In the timeline follow back, we go month by month to have our participants start with the most recent day, yesterday, what did you use? And then go month by month all the way back for the past 12 months. And we ask them to be as accurate as possible. We have leeway here, right? We have flexibility. It's not saying like Tuesday versus Wednesday that week really matters necessarily, but just give us the most accurate picture we can. In addition, we encourage our participants, pull out your phones, open up Snapchat, TikTok, whatever you need, go through your calendar and give us as much information as you can. We cue them to saying, hey, this is the week of Halloween. What'd you do for Halloween this year? Hey, it's summertime. What'd you do for vacation? Right? Did you use more on vacation or not? Oh, your parents were out of town. What happened that week? After we get that 12-month detailed period of time, that ideally they come in every single year, and so we'll have detailed to the date, all information. When that doesn't happen, when we have a little bit of a late visit, they miss a year, we then fill in the rest to have an estimated period. And in this one, we go a lot more broad. About how much are you drinking per week, right? What's the total dose? What's your average dose? We can't differentiate on these in these tables, things like weekend versus weekday use. We can't say what their max use was. We can't say that they were co-using on the same day any of these substances. This really relies on them having a clear pattern of use, of repeated use, which only becomes more common as they get older, typically. Since we started this study at ages 9 and 10, we are calculating lifetime use proactively, prospectively, as best we possibly can, so that we can say that somebody has had likely around 1,526 standard drinks across their lifetime, right? So this is really unique, again, strength of our data set. At the start of the substance use interview, again, our staff are highly trained to try to make this as neutral and positive as an experience and easy on our participants as possible. We do remind all of our participants, as soon as we talk about substances, about confidentiality and how we're not going to go and tell their parents about any of this. We're not going to tell the authorities about what they've done. Everything is completely confidential, with the exceptions of any imminent harm to themselves or others. And so our staff go over the script here, saying that we just gone through this yes, no, you said that you've used cannabis and you tried Molly and nicotine in the past year. So we're going to look at measuring that more closely. This is not going to be too hard of a task because I'm going to help you use a calendar like this one. And I'll show you what that looks like in a second. What the calendar does is it gives you a picture of dates and patterns of your substance use. And what we've found is that calendars are very useful in helping recall their drug or alcohol use. The idea is to record the amount of each drug that you've used in standard amounts that you've used on each day. For example, if you drank alcohol, we would measure in drinks, such as a 12-ounce can of beer or a 5-ounce glass of wine. And I'll show you pictures and help you measure. Our staff have a whole binder of different pictures. So if somebody's like, yeah, I had a joint, we can be like, okay, show us what size joint you had. so we can get as close to accurate dosing information as humanly possible. And so the staff go on through this. There's also other tips. We encourage them to use scrap paper. We tell them that they can tell the participant that they can pull out their phones. We ask them to cue things. We ask them to remember as much as possible what drugs the person said, so they can say, oh, you said you've been trying Molly every once in a while, off and on. Did you use any Molly this past month? And so then they go into the substance use, or into the timeline follow back with our participants. Again, the timeline follow back is going to be administered if a participant has endorsed any full use of alcohol or any other drug. These are the variable names listed here if you are interested in looking up those full use variables, those yes/no variables. Again, we're putting everything into standard units, such as shown in this table right here, that for alcohol, we use standard drinks. For tobacco cigarettes, we do cigarettes. The vaped marijuana or concentrates, we do occasions. So how many episodes per day? So did you wake and smoke? Okay, now you're high, you were feeling high. After you kind of came down a bit, you went somewhere else. When did you next use? Oh, you used at lunch. Okay, great. And you start counting how many occasions throughout the day somebody is using. We do take as much information as we can on smoked flower products so that we can convert cannabis into grams. All of this has been coded in the summary tables provided through the MBDC portal, and especially through our DEEP portal. So you'd be able to find summary of the past year's timeline follow back. Again, there's an estimated period, which you can see in this kind of pink part of the table. And so that's going to be outside the past year, and we're not going to get as much dosing or day-specific information from participants. And so when we go through the timeline follow back, this is what our participants see. So in those dark boxes on the calendar at the top, that shows when the past year substance use module occurred, or that's how far that our RAs are going through. And they're putting in all sorts of different information. Alcohol for standard drinks, right? Labor Day, holidays are auto added on. And then they can go through and they can add specifically, on this day they added smoked cannabis flower and how many grams based on what kind of flower they use in the products and in some of our conversion tables. And so the other thing I wanted to highlight again is that we do try to get the best age of onset information we can. So this can be gated into based on that. Was this the first time that you tried alcohol or any substance question? When did you first try electronic nicotine or vaping products? And we do have these date of first use information. You can also do it just based on their timeline fallback. When do they first report it in the timeline fallback versus when they were gated into it the first time they report a substance use. Now, I'm going to show you some pictures here from the DEEP different mapping that our DAIRC has put together. And so the bottom of this screen here shows you if you're on DEEP, which I highly recommend using DEEP as much as you can to look through our data dictionaries and even access and pull down the data once you have your ducks. But you can click through and get through substance use patterns, and into the youth area. And there's 3 different modules that I want you to be aware of because each of them provides overlapping but different information on our substance use from our participants. So the first is the substance use interview, pictured here. The substance use interview is the overall introduction into substance use during annual assessments. All participants complete the substance use interview, including at baseline when they said they hadn't heard of any single substance. That's all part of the substance use interview. So have you used since we last saw you a full drink of beer, wine, or liquor? Yes, no. All heard of, all low-level use, all follow-up questions, those first time they've used is in the substance use interview. The next module that's important to know about is the timeline follow-back. So this is detailed patterns of use. And again, there's a lot of summary variables available for you within this table. You can see a snapshot of that in the data dictionary on the bottom right part of the screen. This is everything we just discussed, right? The summary variables of all of those calendars and all the information that our staff are painstakingly going through with our participants. and we're going to talk more about in a second. And then we have the mid-year phone interview. The mid-year phone interview occurs for almost every single study visit. We did skip 1 year, but at about 6 months after their study visit, they get a phone call, or eventually they get sent a remote survey to complete to answer just, since you were last in, have you used substances? And so this just gets us a little bit more information, intervening information. It helps staff that they can go back before the visit and they might see, oh, they endorse that they've been using substances. I know I need to make sure I have everything in order to do that timeline follow back, and I need to plan the time and spread out the protocol to make sure I have time for the full timeline follow back because this youth is already endorsing substances. And then, so these are our 3 different modules. So there's the substance use interview, timeline follow back, and the mid-year. Both the substance use interview and the mid-year are going to give you just a basic yes, no. That's great, helps you know whether or not somebody's been using. But if you most want to capture all past year substance use, it may be best to actually combine it across these 3 measures. So what we've seen in various reporting and through our own data analyses is that there is some variability in reporting across measures. Somebody might endorse on the mid-year interview that they're using substances that they don't then tell us about during their in-person visit. So if you combine across these 3 measures, you will get the highest prevalence rates. And I'm going to show you a bit of that data in a few minutes. The caveat to this and thing that you need to be aware of is that this will only give you a binary yes, no, have they used in the past year, or have they used in their lifetime if you combine across years as well. It does not identify patterns of use. You can't then say, if somebody's only reporting during the mid-year interviews that they're using alcohol, you can't then say, well, they've used X amount of alcohol, or they're binge drinking, or any other such pattern. But if you're looking just for prevalence, if you're looking to most comprehensively be able to say who has engaged in substance use versus not, combining across these measures is most helpful. If you, like me, are most excited about all this timeline follow-back data, then you're going to want to log onto the MBDC portal, which is separate from the deep images I just showed you, and download the raw timeline follow-back data. Then you can calculate your own date ranges. Do you want to see just their past week use? Do you want to look at those who have episodic drinking for 4 weeks in a row? What do you want to look at? The really exciting thing is, again, thanks to our wonderful DAIRC, Janosch, Olivier, and their whole team, there's code to help. And so this is available through GitHub. They've actually made an R package. Everything that you see on the bottom part of the screen here is available on this website. And this code here, you'll be able to copy and paste into R. I've done it myself. I am not the strongest in R, but they made it easy to follow along and do. So if I can do it, I assure you, you can do it. But you can first see how they've actually coded all of the released summary variables, as well as adapt their code for your own purposes. So highly encourage you, if you want that raw ABCD timeline follow-back data, please look into this information because it's really invaluable and can save you a lot of time. So the fun part, you know about the protocol. What questions are you going to ask? So if you are focused on age of onset of use, you want to know about who's used before age 16 or before age 17. You're going to want to do things like search, and this is the DEEP portal, again, looking at their data dictionary. If you just type in onset_DT, you should get the dates or the onset ages for participants based on their self-reported when they first used each substance. If you're interested in co-use of substances, here you can search DEEP for _co_, especially if you're within those timeline follow-back information sections. And you'll see cannabis co-used with nicotine or whatever other substances you want to look at. This will guide you straight into it. Do you want to look at recent use or exclude for recent use? Again, go to the plus form, just click through their little mapping guide, and that will get you to the plus form. Do you want to know about when they last used? _last gives you the last use date. Again, you can do comparisons with their session date then to calculate how long it's been. Or you can search for CUM_ABST to get length of abstinence. If you want to see if they're underreporting of substance use relative to hair testing, which is one of my bread and butter at the moment and just my love of all hair testing things, and we do see that there is a lot of underreporting of substance use in our participants, though it is improving, and that paper will be live on a preprint server soon and hopefully published not long after. You can combine the 3-month summary data from the timeline follow back with hair testing. There is a caveat to that. I'm going to tell you more about that 3-month data in a few moments. Do you think that it's really just the last month of use that's most relevant? Forget lifetime use, forget past year. If that's the case, look for the summary data that only has the _1MO_. And then again, if you just want to control for whether they used at all, you're not even concerned about the timeline follow back or the mid-year interview. Just look at the substance use interview to look at yes/no reporting on its own. So all of that, everything we've just talked about, everything has been created carefully and thoughtfully by the substance use work group with the idea that we want scientists and you included in that group to flexibly ask the questions you want to know more about etiology, risk, resilience factors in adolescent substance use. This requires a thoughtful combination and coding of data to be able to answer these questions, but it is possible. Again, there's a lot of measures in this protocol. There's a lot of different ways to ask things, code things, but I bet you we can do most of what you want to with this data set. You just have to think about and figure out how to get R to work to your fashion. You can use the detailed measures in those pre-calculated measures. You can also look at the estimated measures as much as you want, depending on what your research questions are. And I will say again, I know this takes a lot of thought. The decision points can seem endless. If you want to look at just standard dose of each drug across a cumulative period or just the detailed period. Do you want to look across all drugs? In which case you want to make sure you're looking for the total use of days estimated plus detail. You can look at cannabis products all together, or you can look at how much they're using edibles, how much they're using concentrates. We make our best we've done our best effort to try to calculate even standard units across all these different types of products. If you're looking at nicotine, you can do the same thing. Do you want to combine across nicotine products or only look at specific nicotine products? For alcohol, do you want to look at sipping, alcohol use that was more than a sip? Do you want to look at total alcohol use or binging and then that their subsequent hangover symptoms? All of this is fully possible. You just, again, have to think about it. And so I'm going to end by talking about data and what it actually looks like, because some of you might be saying, hey, I've read those early papers and the cohort's not using that many substances. So I thought it'd be helpful to say, hey, we do have substance use going on. And you can see this in our ABCD 6.0 data release. This data is now out and available. In the data I'm presenting here, as it's been, the prevalence estimates have been measured, done by a wonderful postdoc here at UC San Diego, Dr. Ryan Sullivan, with the help of Dr. Alex Wallace. This is what our substance use is looking like right now in our cohort. So you can see clear escalation from year 2, when they're about 11 to 12, to year 4, when they're 13 to 14, to year 6, when they're 15 to 16. That almost a third of our participants have used any substances or used a substance in their lifetime by ages 15 to 16. And this really does map on a lot more closely now to things like monitoring the future. As I've already mentioned too, we know that their substance use reporting is getting more accurate because our objective measures through hair toxicology are also showing us a similar pattern. We also know if you're interested in sex differences, which can be incredibly important in all areas of research, but that means that in substance use it is just as important. We do see that there are some subtle but present differences in substance use reporting based on sex as assigned at birth between females and males. And so you can see that females are actually using at slightly higher rates than males for alcohol, as well as actually all other substances too. And this is again looking specifically at our 15 to 16-year-olds in the year 6 and the 6.0 data release. So Final thoughts. Make sure you're thinking about gating. Not every question is automatically given to all participants. So you want to think about why is it that some data might appear missing. It might not actually be missing. Think about the plus form if you're wanting to control for recent substance use, and you can even match the date of the plus form to the administered element of the protocol. Make sure you're aware as best you can be of when we give each measure, because attitudes, expectancies, and motives vary in administration year to save participant burden. Check out what our pre-calculated timeline fallback variables already are. There's clear code in an R package to help you calculate your own patterns. If you are interested in that past 3-month use, please do check this package specifically, because after the data release was finalized, unfortunately, we realized that the 3-month patterns were scored as past 60 days in 6.0. A patch will be coming out for this, but if you're watching this video as soon as ReproNim launches in fall of 2025, that patch will not be live yet. So it is super easy to correct. Again, I've said I've done this myself. It's not difficult, and you can reach out if you need help with anything. The other thing to think about is that more administrations are given remotely over time and during certain periods. So of course, during the COVID pandemic, most of what we did was remote. There are some modest differences we know of during COVID years in reporting on attitudes, expectancies, and use patterns based on administration type, but they're very modest. We're not seeing drastic changes. But think about whether or not you want to control for type of administration, if it matters for your research question. And if you want some data on that, we've published that in Substance Use and Misuse in a 2024 article. And with that, I will say thank you. I'm a huge fan of ABCD-ReproNim. I have nothing to do with it beyond this lecture, except that I tell everybody to go check it out. So Dr. Angie Laird and the entire ReproNim team really need a lot of credit. They are phenomenal for putting all of this together. Our ABCD participants and families, obviously we could not do this without them. They are truly incredible to work with. It's been a minute since I ran sessions, but it was always super fun. These participants are dedicated to this study, to the science. They're excited about it, and they're still excited about it, even as they're starting to enter college and all sorts of other things, which is really fun to see. Our staff make the engine of ABCD run. Everything I've just told you about, all these protocols and everything you might be feeling a little bit confused about right now, our staff know it like the back of their hand. We are so grateful to them for all the effort they put into making this data collection possible and as high quality as possible so that we can answer these really important research questions. We're, of course, immensely grateful to NIDA and our funders at NIH and beyond for providing us this opportunity to answer these questions. And then, again, I want to just highlight Dr. Alex Wallace, Dr. Ryan Sullivan, and Dr. Crystal Lisdahl for all of their contributions to the substance use protocol and all that they do in the ABCD study. If you have questions, feel free to email me or any of the actual work group chairs of the substance use work group. And then I'll finally just say I am very grateful for my own lab and our data collection site. And thank you for being interested in this data. Hopefully this can be of use to you. Thanks so much.